tracheostomy, okay? So if the patient is in trismus, you are literally up a creek, because it means that you cannot you can't put in an oropharyngeal airway, you cannot do an intubation from above, and hence you have to call the ENT surgeons to do a tracheostomy. What are some, okay, I think we already sort of said it. What are some causes of trismus you can think of? For the person who said the layman's term, why, typically when we say somebody has lockjaw, what do we see that in?
Tetanus.
Tetanus. All right. All right. So other symptoms patients may have would be the dysphagia. We already spoke of the fact that you can have children in the tripod or the sniffing position. They may have altered phonation. Do you know of any condition? Do you know of any medical problem that can result in altered phonation or a muffled speech? You have done it already, you know. That's why I asked the question.
Stroke?
No, well, yes, stroke, but something that might indicate, yes, stroke, okay, I asked for it, but something that might indicate to you that this person may be at risk of losing their airway. Have you heard of a hot potato speech? What do you get that in?
Hot potato speech. I can't recall hearing about that.
Quincy.
In peritonsillar abscesses.
Yes, yes, yes. Okay. All right. Yes. All right. So other in your evaluation, patients may have altered mental status because of the degree and prolonged degree of obstruction that they're having, or they may have fatigue, or they may be fatigued, sorry. So in the assessment, let's repeat again. Patients with stridor, maybe sometimes you may have patients who are extremely ill, and intervention should precede the diagnostic workup. Certain acute etiologies such as epiglottitis and bacterial tracheitis will likely require immediate airway intervention. If the clinical setting suggests the patient is stable, but airway intervention will likely be needed shortly, the patient should be transported to the OR for anesthesia and an ENT airway intervention. So we said here, for unstable patients, they require intubation in the emergency department. So typically, we would insert an endotracheal tube that is a little bit smaller than the age-calculated size, because you have to take into account the edema that is in the airway due to the underlying illness. So have you done anesthesiology?
Not everybody, doc, like myself.
Okay, so, oh, you answered quickly. I thought you did it. So for someone who has done anesthesiology, how do you determine the size of the endotracheal tube? How do you select the size of the endotracheal tube? Like, let's say if it is a newborn, what size ET tube would you select? Hmm? Who did anesthesiology?
I haven't done NS yet, but just a suggestion to make the screen a little bigger. You see where notes is at the bottom, could you click that?
Say that again?
Right. The slides with a lot of words, it's hard to see because the screen is really small. So
Oh, hold on. But I asked a question and I'm saying it, so you don't really have to read it. Okay, but I asked a question. Can somebody answer that? Let's say Haley. Haley?
Jack,
Yes.
I think it's I did honest, but I'm not sure. I think it's age over 4 plus 4 or something like that.
Okay, okay. So let's work that out. If it is that okay for the person who wanted the slide bigger? All right. So let's work that out. You said, let me hear what you just said, sir.
Age upon 4 plus 4.
Age on 4 plus 4. Okay. So if the patient is 3 months old, what size endotracheal tube can you use?
I'm not sure.
So first of all, you have to tell. So let's say age in years. Okay. What size tracheostomy tube would you use if the patient is 3 months old? A 3-month-old, age in years. What does that age translate to?
It's a quarter of a year.
Okay, let's say 0 years. Okay, age in years,
Yes.
0 years.
Okay.
Okay, you said plus 4 equals how much?
Is that 4?
Divided by 4 equals how much?
1.
Okay, so you're saying that the size of the endotracheal tube is going to be 1, right? That's what you're saying, right?
I mean, that don't sound right, but I guess.
I know it doesn't sound right at all. So it's actually age in years plus 16 divided by 4. So with a newborn, ideally, a full-term newborn infant, ideally, you should be able to intubate them with a size 4 endotracheal tube. Age in years, 0 plus 16 divided by 4 is equal to 4.
Excuse, isn't that the same thing?
Oh, well, work it out for me then. How is
Yes,
it the same thing?
it is.
It is? What did he say before? What did he say before?
He said age over 4 plus
Uh-huh.
4.
Okay, so work that out for me then.
But
What did you get?
I get the same thing. Because if it's
What
age
you got?
plus 16,
Say that. No. Work it out. What did you get?
yeah. If you use 4, then it would be 8 over 4 plus 16
No,
over
no,
4.
no. You said that age plus 4 over 4 is the same as age plus 16 divided by 4. Work out the age plus 4 over 4 for me. Tell me how much you get. What do you get?
Oh, yeah, just get 1 there.
You get 1. And when you work it out with age plus 16 divided by 4, what do you get?
Yeah, get 4.
Is it the same thing?
No.
Okay, all right. Okay, cool. So you'll never forget it, all right? Okay, great. Okay. So what we're saying now, right. So there are times now it can be very difficult to intubate a patient, particularly like an adult who has a laryngeal carcinoma. And sometimes we have to intubate them by utilizing a flexible fiber optic scope. And I'll show you a photograph of that. So there's some,
Sorry, Doc.
yeah?
the screen is cut off again.
Well, I just don't know what to do. I think the screen is cut off again. Let's try this. Uh, is it still cut off?
That's okay now.
I'm not, okay. All right. All right. Um, okay. Yeah. So we said that there are times intubation might be very difficult. You might have to intubate the patient sitting up. So that means now you can't hyperextend and utilize your laryngoscope to intubate. You actually have to do an intubation through the nose by utilizing a fiber optic scope. Okay? All right. A surgical airway kit should always be by the bedside in case of sudden complete airway collapse. Supraglottic airways may worsen upper airway obstruction by the pressure they exert on the epiglottis. So we had already mentioned that. And typically, or usually, we generally pre-oxygenate patients prior to attempting intubation. So this is an endoscopic view of the upper airway. And what you notice, so this is the airway, you just notice this little chink here. This represents a very inflamed epiglottis. So the diagnosis here is acute epiglottitis. You notice the child is pulling and drooling. There's a lot of saliva here, okay? If the child swallows, you have complete obstruction, okay? So the long and short of this is that if the patient has acute upper airway obstruction, you need to know how to manage it, all right? Now, for acute causes that require urgent management, initial steps should involve you stabilize the patient, you start high flow oxygen, you alert, this is what you need to remember, you alert your specialist, such as your ENT surgeon and your anesthetist. You try to suction secretions just in case there may be a foreign body, particularly in the pediatric age group. There's no harm in giving steroids because, one, it could be an allergic or anaphylactic reaction. And two, if there is a foreign body in the airway, you know, maybe it may have caused a little bit of irritation and associated swelling and edema, and thus you can give steroids to reduce that a little bit. You take bloods, obviously, for ABG and cultures if indicated. Now, remember, if you think that this child has acute epiglottitis, do not attempt to insert a tongue depressor, and neither do you attempt to take bloods, okay? You do that after you have established an airway. So you need to decide if the patient is really unstable, you stabilize them first, okay, with an airway. So remember, there are a variety of airways that you can use. You can use a nasopharyngeal airway, an oropharyngeal airway. You may have, if that doesn't relieve the obstruction or the patient is not being ventilated appropriately or you can't oxygenate them, then you have to go to an ET tube. If you cannot put in an endotracheal tube because of an obstruction, right, you need to bypass that by doing a tracheostomy, and that is in the emergency situation. Another thing you can do in the emergency situation, as is here, is a cricothyroidotomy. That's where you create an opening between the cricoid and the inferior border of the thyroid lamina in the midline itself. So this is a lateral soft tissue view of the neck. From posterior to anteriorly, again, you know that there is loss of your normal cervical lordosis. You can see marked increase in the pre-vertebral space. You can see some air pockets, and what this patient has is a retropharyngeal abscess, which is encroaching on the airway from posteriorly, resulting in upper airway obstruction. So the diagnosis is critical. Initial management steps should be initiated. before the results of the investigations are back, and definitive management steps will vary depending on the underlying cause. Okay, but in all cases of patients who present with upper airway obstruction, your goal is to visualize the airway, because that's the only way you'll know what's wrong. All right, so that's where we as ENT surgeons come in, and we can utilize a flexible scope which goes through the nose, bypasses the nasopharynx, and looks at the pharynx. Or alternatively, we can use the Hopkins rod. And if you Google, you'll see photographs of that. Imaging studies can be done in selected cases. So if you think the patient has a massive multinodular goiter, or they may have an abscess, clearly, or they may have a malignancy or bronchogenic cyst. All right? If you believe that the problem is below the level of the glottis, then usually telescopic laryngoscopy or flexible nasopharyngoscopy will not be able to visualize areas below the glottis, and hence that patient has to be examined in theater. We utilize tracheobronchoscopy, okay? And that's when you're going to be able to diagnose other things that are below the level of the glottis, like subglottic stenosis. Okay, this is the flexible nasopharyngoscope, which can be used to examine a patient who's stable and that patient who's in stridor, and it's also used to facilitate an awake intubation. So the treatment of stridor is tailored to the cause of the stridor. You know, we said that there are multiple causes of acute stridor. It may be congenital, it may be acquired. Typically, if it is due to a structural cause, then we can address it at the time that we see the patient, or we create an airway via tracheostomy tube and then address the structural problem when the child is a little older. So the take-home points here are, there are wide differential diagnosis for stridor, but this can be narrowed based on the timing of the stridor in the respiratory tract, the age of the patient, and the onset of their symptoms. Rapid intervention should precede diagnostic workup in the ill-appearing patient. Intubation for ill-appearing patients should be performed by obviously proficient personnel, and a smaller ET tube should be ready for a smaller than anticipated airway due to edema. Stridor, fever, and rapidly progressing symptoms are most likely seen in patients with acute epiglottitis or bacterial tracheitis. In an afebrile patient with stridor and progressively worsening symptoms, consider foreign body, anaphylaxis, for example, okay? A clinician with appropriate airway equipment should accompany stable patients to radiology in case they deteriorate. All right, so let's talk a little bit about tracheostomies. So a tracheostomy is a surgical airway that is made between or communicates the skin with the trachea. All right, so there's a direct communication between the trachea and the overlying skin. So in this schematic diagram here, you notice a cuffed tracheostomy tube is inserted into the trachea. Now so a tracheostomy is a formal or a surgical opening that connects the overlying skin directly to the trachea. So it's a communication. A tracheotomy simply means you make an opening in the trachea, and there is not, and you do not have a direct communication with that opening and the overlying skin. Okay. So when do you perform a tracheostomy? Basically, you perform a tracheostomy when you are unable to establish another airway via the other means that we spoke about. So you can't establish an airway and thus oxygenate the patient appropriately with a nasopharyngeal, an oropharyngeal, or an endotracheal tube. Okay, so the indications are one, to maintain a patent airway when the ability to do this is impaired or compromised as a result of obstruction. So let me repeat, it is the need to maintain a patent airway due to obstruction. And the causes of obstruction can be a tumor, you can have edema, it can be due to a foreign body, an airway can be obstructed because of blood from trauma as well, or because of ongoing secretions, for instance, maybe because of a stroke. Another indication is for tracheobronchial toilet, and that is particularly in patients who have anything that causes depression of the respiratory center. And the typical cause is usually neurological causes. So any cause of what should I say? Well, there are multiple causes of anything that causes a depression of your respiratory center. Okay, so just think of any cause of stroke or any cause of a coma, I should probably say. If a patient is comatose for whatever reason, that patient requires a tracheostomy for tracheobronchial toilet because they cannot protect their lower tracheobronchial tree. They cannot cough to clear secretions from the lower tracheobronchial tree. So any cause of a coma, whether it be trauma, status epilepticus, status asthmaticus, whether it be a stroke, whether it be drug-induced, whether it be alcoholism, all right? So these are causes or indications for tracheobronchial toilet. Another indication is respiratory failure from whatever cause. An example is COPD. We also do tracheostomies for patients who require extended or prolonged mechanical ventilation. So these are patients who are intubated in the intensive care unit, but we cannot extubate them or wean them off the endotracheal tube. So the typical time we say when we intervene with a tracheostomy is we give them 10 to 14 days, so more than a week. Why do we give them more than a week? You just give them time just in case you try them, you extubate them, see if they can breathe on their own. If they cannot, it means that you have to tracheostomize them. So a relative indication for tracheostomy is for elective head and neck surgical procedures. So for instance, if we're operating on a patient who has a squamous cell carcinoma of the tonsil, we cannot see what we're doing. We cannot resect the lesion if the ET tube or the endotracheal tube is within the oropharynx. We're not going to see. So what we simply do is bypass that site by inserting a tracheostomy, and it means that we no longer have to compete with the anesthetist to see the airway. So how do we do a tracheostomy?
Hello.
Hi, yes.
Morning, Doc. So I just have a question. You said that one of the indications of tracheostomy is to protect the airway in a comatose patient.
Mm-hmm.
So I'd just like to ask, so are you saying that patients who are in a coma, they should get a tracheostomy tube?
No, that's not what I said. I said when you assess that patient, so when patients are in a coma, for whatever, there are multiple causes. If you think that that patient is at risk for aspirating on their secretions, because sometimes patients may be comatose and perhaps they're probably able to swallow or they're not choking on their secretions. So not every patient who is in a coma, because sometimes you can have a diabetic who goes into DKA and we don't necessarily have to tracheostomize this patient. That patient may be intubated, for instance. But the anesthetist, especially now, if, for instance, there are no ICU beds, we may be called to tracheostomize this patient, then I will have to make a decision as to say, okay, shall I go ahead and tracheostomize this patient who is a diabetic, have an infection, a tube in their neck, and put them at additional risk for infection of the tracheostomy site? Or is that a patient who can actually protect the lower tracheobronchial tree? They still have a little bit of cough. They can be effectively suctioned. If they can be effectively suctioned and they're not aspirating, then maybe I don't need to put in a tracheostomy tube. But I say that for you as an easy way to remember causes or indications for a tracheostomy.
Understood.
Okay, so another thing is that, we see a lot of trauma and we just have so many ICU beds and no more. So there are times when we have to tracheostomize patients who come in with severe head injury because we just do not have enough. Trauma is big in Jamaica. We just do not have enough ICU units. So now with COVID, the ICU units are being taken up by those patients. You still have your trauma patients coming in. So what we will do now, because those patients cannot protect their lower tracheobronchial tree, they are unable to clear their lower tracheobronchial tree. They need mechanical ventilation. So what we do is that we would bypass that, we would give them a tracheostomy. So it's easier now for the nurses on the ward or the doctors or the interns to suction the airway. Okay? All right? Okay. So how do we do a tracheostomy? So once you have identified the indication and recognize that, okay, this patient will really benefit from a tracheostomy, you do your consent form. All right? So typically in your consent form, you discuss, if the patient is unable to sign the consent form, clearly we need their legal guardian to do so. Okay, you discuss the indication for the tracheostomy, the risks and the complication of the tracheostomy. Okay, now the tracheostomies are best performed in major operating theater. When I was in England and in the Bahamas, we had everything available so we could do a tracheostomy by the bedside. Things are a little bit different here. You need appropriate lighting, you need appropriate bed, you need appropriate suctioning. Okay, so ideally we do it in theater because the conditions are not ideal on the ward. Okay. Next, so it's a sterile procedure. All right, so we typically, the site for the tracheostomy is cleaned, the patient is draped, and we typically gown up for doing a tracheostomy. You select what you believe to be the appropriately sized tracheostomy for your patient. I usually, if it's a man, because men are bigger than women, the size of the tracheostomy tube varies from about size 8 to 9. If it's a female, we typically select a size like a 6, a 6.5 to a 7, 7.5. All right. The next thing is that we can infiltrate with a local anesthetic and a little bit of adrenaline to reduce bleeding the site in the neck at which we're going to make a surgical incision. So the surgical incision is made midway between the cricoid cartilage and the suprasternal notch, 1 or 2 fingers breadth above your sternoclavicular joint. The patient is positioned on the bed on a shoulder roll, and the head is hyperextended. So in hyperextending, you bring most of the trachea upward into the neck, and it's also closer to the skin or more superficial. Now, the isthmus of the thyroid gland overlies your 2nd to 4th tracheal rings. Ideally, when you make an opening in the trachea, you want to do it in either the 2nd or the 3rd tracheal rings. Perhaps if you do it within the 4th tracheal ring, once the patient is in the neutral position, that 4th tracheal ring might be retrosternal. And what that simply means is your tracheostomy tube might be encroaching right here on your suprasternal notch, which would be indeed uncomfortable for the patient himself. Okay, you do not violate the cricoid cartilage, neither the 1st tracheal ring. Because if you do that, the cricoid cartilage is the only complete ring of the airway. If you compromise it, you subject the patient to the ongoing problems of subglottic stenosis. So we know where to make the incision, we have positioned our patient appropriately. You make your skin incision. The layers that you go through are the skin, the subcutaneous tissue, the platysma. Then you come on to the anterior jugular veins, which run on either side in the anterior neck. You resect that. Then you come onto your investing layer of your deep cervical fascia that invests your strap muscles. So you simply separate the strap muscles in the midline with a retractor. You do not cut it, with a retractor on either side, a Leinenbeck retractor, and just play the muscles laterally. The strap muscles that you come onto would be your sternothyroid muscle. Okay, and which other one? Your sternohyoid muscle. All right? So your sternohyoid muscle first, then your sternothyroid muscle next. Okay? Once you reflect those muscles laterally, that should bring you to the isthmus, which overlies the 2nd to 4th tracheal ring. You have to be careful because you can decide to sort of pull the isthmus inferiorly to expose the 2nd and 3rd tracheal ring. But or you can pull it upward to expose the 2nd and 3rd tracheal ring. But what you have to remember and what you have to be prepared for is, what if that patient inadvertently extubates? What do you think will happen? The isthmus will simply slide over and occlude the opening that you've made in the trachea, and thus you will not be able to reinsert the tracheostomy tube. Okay, so the better thing to do is perhaps divide the isthmus of the thyroid gland between clamps and tie it off. So you don't have to worry about what if. So once we've done that, we've exposed the anterior aspect of the trachea. So remember, ideally, we want to make an opening within your 2nd or your 3rd tracheostomy ring. Now, what you do in the pediatric age group is different from what you do in the adult. Because in the pediatric age group, the tracheal rings are not fully matured. So you don't want to remove a piece of it or resect a part of it, because you will compromise healing, and maybe you'll have a child who develops tracheal stenosis because they'll be healing with scarring and fibrosis. Okay? So what we do in the pediatric age group, like usually up until about the age of 12, is that we make a vertical opening. So we make a slit, a vertical opening, midline in the anterior aspect of the tracheal ring. So typically it would probably involve the second and third tracheal ring, an opening wide enough to accept a small endotracheal tube. Okay? So we do not violate that immature cartilage. In the adult now, we actually make an opening in the anterior aspect of the tracheal ring midline. You don't want to go too far laterally on either side because you may damage the recurrent laryngeal nerve. So we create a little window in the tracheal ring, tracheal ring. Once you've done that, you think the opening is wide enough to accept the tracheostomy tube. You check your bulb of your tracheostomy tube and to ensure that the bulb is functioning, because remember, most of these patients will perhaps be attached to a ventilator and we do not want air escape. Okay, and then you insert the tracheostomy into your trachea and secure the tracheostomy to the neck by utilizing ties. Thereafter, the surgical incision on either side of the tracheostomy tube, we just put in one suture on either side. So your post-operative instructions after surgery are very important. And your instructions are aimed not only at the device, but also at the tracheostomy site. So your instructions are aimed to prevent or to ensure that the tracheostomy tube remains patent and clean, because this helps to obviously prevent a clogged tube and decreases the risk of infection within the airway. And the tracheostomy site, obviously, it's important to look at it or to remember that in your post-op instructions, because you don't want the site to become infected. So for your tracheostomy care now, it's important that you remember we said you do not want your tube to become obstructed. And the reason why that is so is because if the tube is obstructed, it means you have to change it. If you change your tube before 3 to 5 days of it actually being maintained in place, it means that you may actually lose that tract. The tract hasn't formed as yet, and it's at risk for closure if you remove the tracheostomy tube. So that's why it's important to pay attention to frequent suctioning. You have to humidify the inspired air at the level of the trachea and also provide oxygen. Okay, so we generally write in our instructions to frequent every 2 hours. Okay, we apply humidified oxygen because remember now, the patient has lost the function of the nasal cavity because you have bypassed it. So the function of the nasal cavity, or one of the functions of the nasal cavity, is to humidify inspired oxygen for exchange at the level of the lung. So what it means is that right away, the patient is obviously breathing through the tracheostomy tube, and because of the reduction in the humidification, then you can have a lot of crusting within the tracheostomy tube. So that's why we ask for humidified oxygen. It's also important that you administer deep physiotherapy to encourage breathing and coughing in the awake patient, and it's also used in patients who are intubated. You need to hydrate the patient, and remember, there's a foreign body in the airway. You need to protect the patient by putting them on just a short course of antibiotic therapy. You also have to address the cuff pressure because one of the complications of a tracheostomy or even an endotracheal tube is tracheal stenosis from persistent pressure of the cuff itself. Okay, so in our notes, we will say deflate the cuff for 5 to 10 minutes every 2 hours. So that means you prevent ischemia to the perichondrium, and thus you prevent death of cartilage with healing, death of cartilage. And if you have death of cartilage, it means you'll have fibrosis and scarring and thus tracheal stenosis. So this is a schematic diagram that basically reiterates what we said before. Sometimes you may actually have to divide the isthmus of the thyroid gland. And this is a tracheotomy. That's what we do in the pediatric age group. We do not violate the tracheal ring. We just make a vertical incision and then place the tracheostomy in that tracheostomy tube. All right. So there are many types of tracheostomy tubes, and they can be cuffed or uncuffed, single or double lumen, fenestrated or non-fenestrated, metal or portex. This is a double lumen, 1 lumen, 2 lumen obturator. So a double lumen cuffed, you see it here, plastic tracheostomy tube. So once we have a double lumen tracheostomy tube, it indicates that we use that in patients who require a permanent airway, but they do not require ventilatory assistance. So we basically send them home with a double lumen tube. Okay? So the purpose, so basically, let me describe this. Let me talk about the parts of a tracheostomy tube. The components of a tracheostomy tube are as follows. You have the flange, which is here, that has holes. And this is through these holes, we pass ties that are used to stabilize and secure the tracheostomy to the neck. This is the outer cannula. This is the inner cannula. The outer cannula, so this is a double lumen tube, which you realize, okay? The outer cannula remains in place in the neck, and this inner cannula is what comes in and out, and the patient cleans this. So the tip of your inner cannula can extend beyond the tip of the outer cannula, and that is important because what it means is that secretions, crust, debris would accumulate within the tip of the longer cannula, which is the inner cannula, and if it gets blocked, the patient can remove it, clean it under the tap with running water, soapy water, and a bottle brush, dry it, and reinsert it. So once again, this is a cuffed, double lumen, plastic, fenestrated tracheostomy tube. We already said that there's an outer cannula, and the flange is attached to the outer cannula, and the inner cannula is removable for cleaning. In the previous image, here, this is the obturator, okay? And this obturator, at the time of doing your tracheostomy, is inserted in this. The tip extends beyond that, and hence it allows you to insert the tracheostomy in place atraumatically. The cuff soft balloon around the end of the outer cannula is inflated to allow for mechanical ventilation. And here we have that the sizes of a tracheostomy tube can range from about a size 3 or 2.9 to an 11. So let's go again. Double lumen, cuffed plastic tracheostomy tube, this is also a double lumen metal uncuffed tracheostomy tube. It comes with a series of inner cannulae. So we need to know the complications of a tracheostomy tube. When we talk about complications of any surgical procedure, I want you to tell me complications can be intra-op or post-op. Let me start again. Right. Intra-op complications can be related to the anesthesia, or it can be related to the surgery. Likewise, your post-operative complications can be related to anesthesia or the surgery. But because I'm a surgeon, in the end, all I'll tell you is, okay, let's hear your complications related to the surgery. But there's a way in which you answer the question. So your intra-op complications related to the surgery include loss of the airway. What I mean by that is that you may think that you inserted it into the trachea and suddenly you have lost, the tube has come out and perhaps gone into the soft tissues around on either side of the trachea. Another complication may be hemorrhage, which may be either from venous or from arterial vessels. You may damage the posterior wall of the trachea and thus the anterior wall of the esophagus. So that has a long-term complication, meaning a tracheoesophageal fistula. You may damage the cupula of the lung if you go a little too far laterally, and the patient may end up with a pneumothorax. The patient may aspirate parts of either the trachea that you're excising, or they may aspirate on blood. You may damage the recurrent laryngeal nerve if you damage, and that is important because obviously sometimes the tracheostomy is just temporary. And you may have to extubate the patient. And now you have a patient who is in stridor because you damage both recurrent laryngeal nerves, okay? Post-op complications may be early, intermediate, and late, but I've simplified it here into early and late. Early complication may be, again, hemorrhage. The tube may become obstructed, and thus the patient desaturates. The tube may become displaced just by simply moving the patient from the operating bed to the stretcher to transfer them to ICU. You may go into a false passage, as I said before. There may be surgical emphysema. Late complications are related to scarring and fibrosis that results now from injury that you have done during the operation. Okay, or injury that has been sustained, or damage that has been sustained during the operation itself. So you may have tracheal or subglottic stenosis, a tracheoesophageal fistula, a tracheocutaneous fistula. You can still have dislocation of the tracheostomy. You can have bleeding from the stoma during suctioning, and you will always be at risk for blockage during a tracheostomy tube once you have a tracheostomy tube inside. Okay? Okay, that's the end. Did you all fall asleep on me? Oh, somebody has.
So, yeah.
Okay, somebody. Okay, all right. Okay. Are there any questions? Everything understood?
Yeah, well,
Any questions? No.
Okay. All right. Okay. So the group leader can tell me when you'd like me to play those recordings. You can send me an email. I think you have my number as well. And if any of you have any questions whatsoever, feel free to contact me via email.
Yes, Doc. Read the recordings. I usually I let Dr. Ashman know what we would like to be replayed, and he schedules them.
Okay, so are you in the process of doing that? Not quite yet. You're waiting to complete my class.
Yes, Doc. After the class, I'll send him an email to let him
All
know.
right. Okay. So is that it for everyone?
Yes, Doc. Thank you.
All right. Okay. You're welcome.
Doc, I
Take care.
have a quick question.
Sure, Shannon.
Sorry?
Is it Shannon?
Yes, Doc, it's Shannon.
Mm-hmm.
Can you please remind me of the names of the congenital abnormalities you said were
Chuck Collins, Tre, because I have braces, sometimes it's difficult to pronounce. Treacher, Treacher, Collins, and Pierre Robbins syndrome.
Yeah, thank you. And the one associated with the vascular rings?
Dysphagia luxuria.
Okay, thank you.
All right, you're welcome. Okay. All right, guys. Take care.
Thanks, Doc. You too.
Okay, you're welcome.